Our next speaker will be Dr. Shilo Anders. Dr. Anders is a research associate professor in the Department of Anesthesiology, Biomedical Informatics, and Computer Science at Vanderbilt University. She is also a member of the Center for Research and Innovation in System Safety, or CRIS. Dr. Anders?
Thanks. All right. So I thank you for allowing me to talk today, and I have no disclosures. So I'm going to step back and hazard a guess that your current EHR is probably not an ideal workspace. And so when we think about the EHR and other work systems, I like to think of this quote from Larry Hirschhorn. And as soon as we have or add some new technology to our work, we're trying to stretch it to do more and to work in novel ways. And I think that has remained true with the implementation of the EHR. And so our priority when we stretch our systems and use our systems in ways that they were never developed or imagined to do, in healthcare, I think safety should still be a paramount thing that we're looking for. And so in a study by Walsh from 2009, looking at outpatient chemotherapy, 7% of adult and 18% of pediatric visits had some sort of medication. And so sort of envisioning forward, is there an opportunity with the EHR and associated technologies to become more of a system where the EHR is seen as part of the healthcare team rather than a tool to be used? And so that's sort of the focus of my talk today. And whether that is contributing to ensuring safety or providing clinicians with the right information at the right time in a manner that makes it both intelligible and also actionable, I think is really key to better envisioning this world with in life with EHRs. So I'm going to propose two different methods by which it might be useful to explore ways in how we might do this. So the first one is a technique called non-routine events, or an event gathering method. And it's really looking at one, if you think about a cancer patient and their care trajectory, there's usually some sort of optimal care path. And anytime that there's a deviation that occurs, we call that a non-routine event. So it's a deviation from that optimal care. It may be very small and teeny. It may be huge and large and results in some sort of adverse outcome. So the goal here is really to look at and study those deviations and see, are they capturing real latent safety issues or things that we should be addressing that could lead to some sort of catastrophic outcome. So for the past 15 to 20 years, our center, CRIS, has explored these. We first started with clinicians, specifically in the operating room, and then have moved more recently to patients, including cancer patients. So when we implement this paradigm, what have we discovered? So here are a few examples. I'm not going to read them, but of NREs that we've collected from outpatient cancer patients. And so I think that this affords us some insight into what is happening to patients outside of the hospital system that may be really valuable information to clinicians. So if we specifically look at the second one, the patient notes that they use the patient portal to tell their clinician that they were having all these horrible feelings. And so if we think about that, how might that information be more captured than with a patient portal message and conveyed to clinicians through the EHR so that it doesn't become lost in the shuffle and embedded within this portal framework and the messaging rather than, the next time it comes to the patient's treatment, this is readily available for us to see and sort of help make treatment decisions based on it. So there's really this opportunity for the EHR to be more integrated to improve care efficiency and effectiveness in this case. Here's another example. So the patient didn't let anyone know that they were having this excruciating pain for almost 4 days before. And then when they did, they were reminded about their pain medication. So this is another opportunity, I think, for the EHR, the system, to sort of alert either the patient or the clinician that there is this medication available that the patient might not be actually taking or using when they could be. With this method, we can see that most of the NREs really occurred at home so far, and that the vast majority are associated with the cancer treatment that they are receiving. Less than half of those NREs were actually reported by the patient to the clinical care team in some way. And so this really may be a useful way to identify opportunities to improve the EHR by looking at the work as found and captured in the moment by these patient NREs, and especially in the moment outside of the hospital that might still be really important when making clinical care decisions. So I think the other method or approach there's really an affordance or an opportunity to create more optimal care environment is through using a human-centered design approach. So often there's a gap between how we think about how people use the system or technology and its actual use. So if we think about EHRs when they were developed, right, they're developed as systems as imagined. So there's a specific instance that was static, that was deterministic, that we were looking at when they created the design space. And even, the development, the review are all static places in time. And when it's implemented, right, it's put into this really dynamic and that's stochastic, and we're thinking about nuances like implementation and ongoing operations and even ongoing maintenance where we have upgrades to our system. And so human-centered design focuses on an iterative approach to the design environment for systems that seeks to understand how, in this case, the EHR users interact with the system to accomplish various tasks and achieve various care goals. So it's really about better understanding the fit while offering improvement. And so it affords us the opportunity to look at questions like, how do we best get new information to clinicians in additions to the EHR specifically? So if we look at the patient non-routine event space, right, those are patient-reported outcome measures. There are other patient-reported outcome measures. How do we visualize and provide those to clinicians? In what space, when, what data do they really want? How do we use that and use the EHR in conversations around shared decision-making and integrating digital information? And then more recently, I've been thinking a lot about how we show and visualize and share with clinicians these machine learning outputs to really improve diagnostic accuracy and reduce clinician workload. Are they really adding to it and adding more complexity? And how do we make sure that they're not doing that? So in summary, I think that both of these tools or these methods are potentially means to differentiate between work is imagined versus work is found. And those as well allow us opportunities to improve EHR in the real clinical context that are focusing on better understanding and designing for work is found. So and more largely, like, normal work is not well behaved, especially in the clinical environment. And I think that the world is often full of surprises. How often do you walk into your clinic and have the day that you exactly expected, right? There's differences in demand and tempo, especially with different patients as they're going through their cancer care. Stuff doesn't always work as advertised. Patients don't have the responses that we expect. And novel conditions are common, so there's lots of tailoring and adaptation that occurs. But I think that there are opportunities to more closely align the fit of the EHR to the cancer care system so that it makes a better space, workspace, team space, having the EHR as part of the team rather than this thing that we have to go refer to and try to. So with that, I'm gonna thank you for your time, and this work couldn't be completed without numerous collaborators. Same here. And I'm excited to talk more.
Okay. Thank you, Dr. Anders.